Hello, this is Dr. Kevin Kirby, and I want to continue with my fourth part of my series of lectures on the medial and lateral heel skive techniques. Let's talk about, in this lecture, just about the lateral heel skived orthotic technique. Initially, I developed the medial heel skive as a way to control excessive subtalar joint pronation. However, a year or two after that, with the success of the medial heel skive, I started to develop, along with precision intercast, the lateral heel skive technique to treat the opposite problems, excessive supination deformities. And to perform the lateral heel skive technique, which we first started doing in 1992, approximately 2 years after I had developed the medial heel skive, we were able to take the same positive cast and we would shave off, instead of the medial heel and the medial heel skive, we would then take off lateral heel plaster to produce a valgus wedge, and this valgus wedge would be rounded into the cast to produce an intrinsic valgus heel cup in the custom foot orthosis. The lateral heel skive actually increases subtalar joint pronation moments by shifting ground reaction force from a more central location in the plantar heel of the foot wearing the orthosis to a more lateral location, thereby decreasing the subtalar joint supination moments and increasing the subtalar joint pronation moments coming from the orthotics effect by producing a valgus wedge in the heel cup of the orthosis with our lateral heel skive. Well, what are some of the pathologies we would use the lateral heel skive in our own clinics? The most common pathology I treat with the lateral heel skive are peroneal tendinopathies, such as peroneal tendonitis, peroneal tendon tears, or chronic peroneal tendon pain. I've also used the lateral heel skive technique successfully in treating chronic inversion ankle sprains, treating types of lateral column pathologies, such as lateral column overload syndrome or lateral dorsal midfoot interosseous compression syndrome, or any pain laterally on the forefoot that is caused by oversupination of the foot or increased lateral pressure on the forefoot. However, the most common pathology that I use the lateral heel skive for is peroneal tendinopathy, and I will use some of this lecture to talk about peroneal tendinopathy, since it is a fairly common problem that we do treat with the lateral heel skive technique. Peroneal tendon pathologies include peroneal tendon tears, peroneal tendon subluxation, and tendonitis. These were first reported back by Montigia in 1803. The peroneal muscles are very special muscles, the peroneus brevis and peroneus longus specifically, since they are the only strong pronators of the subtalar joint that the human body has. The reason they're pronators is because they pass lateral to the subtalar joint axis, and they're the only extrinsic muscles that can produce a strong pronation moment on the foot. Estimated moment arms for the peroneus longus is 21.8 millimeters, for the peroneus brevis 20.5 millimeters. The bottom line is when these muscles come down from the lateral aspect of the leg and pass posterior to the lateral malleus and attach on the lateral aspect of the foot, or in the peroneus longus situation, it passes through a pulley on the plantar cuboid. These do produce strong pronation forces on the foot, and the body uses these during gait to prevent the foot from oversupinating and causing inversion ankle sprains. Patients that tend to get peroneal tendinopathy are those patients who have a pes cavus deformity, high degrees of riff varus, or high degrees of metatarsal ductus deformities. So the varus calcaneus produces increased inversion of the calcaneus. Pes cavus deformity is generally also associated with a metatarsal ductus deformity, which tends to cause a foot to oversupinate. And then the body's only defense against this oversupination is activating the peroneus longus and peroneus brevis tonically and chronically during gait, which produces these high peroneal tendon tension loads, which produces in turn peroneal tendinopathy. So why is lateral subtalar joint axis deviation such an important concept to understand when we start looking at peroneal tendinopathy? We have to see that in a normal axis foot, again, from the first 3 lectures, we see that subtalar joint axis goes from the posterior lateral calcaneus to around the first metatarsal head. However, when we have a lateral axis, the axis will be quite further lateral to the Achilles tendon, and will also be much more lateral in the forefoot, producing a greatly decreased peroneus brevis moment arm in the lateral deviated foot than in the normal foot. Here's the peroneus brevis moment arm in this foot that has a normal axis. It's approximately twice the length of the moment arm in the lateral axis foot. So the peroneus brevis is going to have to contract twice as hard, and the tension is going to have twice as much force in order to produce the same amount of moment as in a normal subtalar joint axis foot. So this produces high tension loads in the peroneal tendons and may produce these split tears, tendonitis, or even ruptures of the peroneal tendons over time, which can cause these pathologies to occur. So we have to understand that when we have a peroneus brevis and a peroneus longus that are the body's only mechanisms to produce pronation, they're going to be used anytime we have a structural deformity or a movement that produces subtalar joint supination. These deformities could include increased varus deformity of the calcaneus or rear foot, a rigid forefoot valgus such as an everted forefoot to rear foot deformity, or rigid plantar flex first ray, or a high degree of metatarsal ductus deformity. Well, why would metatarsal ductus deformity, a transverse plane deformity, tend to cause increased subtalar joint supination moment? Because when we go to an increased metatarsal ductus deformity compared to a normal foot, when the forefoot is displaced medially in the metatarsal ductus foot, now we have more metatarsal heads medial to the axis than we have in the normal foot. So we can see how this medial shift of the forefoot that occurs in metatarsal ductus will produce an increase in subtalar joint supination moment, which can over time lead to peroneal tendon pathology due to the excessive supination moments that ground reaction force are causing on the foot during every step during the patient's weight-bearing activities. So when we have a axis of the subtalar joint that is laterally deviated, the central nervous system recognizes this, that the foot is going into over-supination or can be supinated excessively with each step, and therefore will increase the peroneal activation, which therefore increases the subtalar joint pronation moments from the peroneals. In other words, the peroneals are fighting this all the time in some of these feet that have high degrees of rear foot varus, high degrees of metatarsal ductus, or a pes cavus deformity. So we can produce peroneal muscle fatigue, tenosynovitis or tendonitis of the peroneals, or peroneal tendinosis known as longitudinal splits or degeneration of these peroneal tendons over time. So when we are using a foot orthosis, such as lateral heel skive orthosis with valgus wedging, which I'm going to describe later in this lecture, we are trying to duplicate the peroneal tendon function by trying to pronate the foot, so the peroneal tendons and muscles don't need to work so hard to do that on its own. So I believe the central nervous system actually recognizes when the orthoses are pronating the foot, so it doesn't use the peroneals so much in order to produce normal weight-bearing activities or function, and therefore this valgus wedging, including the lateral heel skive, forefoot, or rear foot valgus wedging, can decrease the load on the peroneal tendons and reduce inflammation over time, which combined with our treatments, which could include icing and strengthening of the peroneals, reduce their pathology and their pain with weight-bearing activities. So what is the first step in the conservative treatment? In the initial treatment, I will add valgus wedging to the patient's shoes to let them see how this reduces the load. Many times this is almost instantaneous where the patient can feel less pain in the peroneal tendons. We will apply, let's say, a valgus wedging of adhesive felt into the patient's insole or sock liner. We'll start them on icing therapy. We use shoes with firm midsoles. If the patient's symptoms are severe or acute, we'll a lot of times put them in a cam walker style boot or walking brace boot. And subsequent treatment will be custom foot orthoses made with lateral heel skives, forefoot valgus wedging, and lateral arch filler, which I'll show you a little bit later. So let's look at this insole modification that we can use for patients with laterally deviated subtalar joint axis who are suffering from peroneal tendinopathy or other types of pathologies such as chronic lateral ankle sprains or lateral column overload. I would take their shoe insole or sock liner out of their shoe, and I would add one layer of adhesive felt, fairly large here, and then a second layer, a smaller layer here, again, of 3 millimeter felt for a total of 6 millimeters laterally and a total of 3 millimeters thick in the central aspect to produce a valgus wedge not only in the forefoot and the rear foot, but the midfoot. And what this will do is shift the weight on the plantar aspect of the foot, or the ground or action force in the plantar aspect of the foot, more laterally to produce an external subtalar joint pronation moment that is going to be recognized by the central nervous system so that it won't use the perineal so much for gait function. So basically, by increasing the subtalar joint pronation moment with this modification in the insole, the perineal muscles and perineal tendons will have less force in them, and the patient should nearly instantly feel some improvement in their clinic setting. So how does this occur? When we have a normal foot that has a lateral axis, the axis is more lateral than normal. A center pressure in that foot is going to be centralized around probably the second metatarsal. But if we start adding in a valgus wedge, we shift that center pressure laterally. And this is how we've done it with the 2 layers of adhesive felt in the insole, which simulates what a foot orthosis with a valgus forefoot wedge and a lateral heel skive will do for the patient during their weight-bearing activities. So here's the foot orthosis I would use. And so typically I will use a polypropylene shell, either of 3/16 or 5 millimeters or 6 millimeter polypropylene. Sometimes I'll use 4 millimeter polypropylene for smaller patients. We'll put in a 2 to 4 millimeter lateral heel skive, approximately a 16 millimeter heel cup. We'll make the rear foot post flat. I don't want a varus rear foot post because that would tend to increase the varus of the foot during walking and weight-bearing activities. I will also add in Corex or other filler material on the lateral aspect of the orthosis in order to prevent deformation of the lateral longitudinal arch of the orthosis during walking. And then I'll also add a varying thickness of a forefoot valgus wedge, a Corex typically, or you could use EVA. And what this will do is add a valgus wedging effect in the forefoot, midfoot, and the rear foot with the lateral heel skive to produce a valgus wedge effect through the whole foot, which will decrease the stretch, which will decrease the tension on the perineal tendons and should make their pain significantly better as long as they don't have a very significant tear of their perineal tendons. We'll also tend to evert the orthoses. In other words, we may add more wedging laterally as time goes on to increase the valgus wedging, or we may order the orthosis more everted. We'll order an extra thick medial expansion plaster in the medial arch so the medial arch is reduced, because we don't want the medial arch pushing the foot into more supination by having the high medial arch. And we'll also use this valgus forefoot extension as mentioned earlier. This lateral heel skive, anywhere from 2 to 4 millimeters. I've never gone to 6 millimeters of lateral skive. This is a very potent combination with the lateral heel skive, so I would tend to not go too high since you may cause bruising of the lateral heel. But certainly it is important to look at not just the heel skive, but the whole orthosis in order to produce the best effect to reduce the supination motion of the foot during walking and increase the comfort of this patient and improve their gait function. Again, lateral filler material is shown here. Another important aspect of making these orthoses work better for our patients. So some of the observations that I noted when treating patients with these conditions, if the patient has a perineal tendon subluxation, foot orthoses are not going to generally help. Also, a standard root orthotic without a forefoot extension basically are useless and ineffective for treating this. I've learned this the hard way. Adding forefoot valgus wedges, lateral wedges on the midfoot and lateral heel skive are very important to treat these successfully with orthoses. Sometimes you have to evert the orthosis past heel vertical. Don't be afraid to pronate the foot further because you probably won't hurt them if they have this type of foot. We have to make sure that the lateral arch of the orthosis isn't flattening out, so that's why we have the lateral wedge. And mechanically based treatment of these conditions is quite effective. Here's my case report. This was a 51-year-old white male physician assistant that complained of bilateral ankle pain, right, worse, and left. And you can see how he stood on the ground, 5 degrees of forefoot valgus on the right, 7 degrees of forefoot valgus on the left. Here's the subtarsal axis points coming out laterally instead of medially. They're pointing laterally, so the left foot is worse than the right. Here we see the left foot having this axis very lateral. This foot's somewhat lateral, but we can see the callousing. Here's where the foot is actually producing callus to produce a pronation moment on the foot, and the high amounts of ground interaction force caused by the foot supinating in that foot is causing this callousing, both of the fifth metatarsal head, styloid process, the fifth metatarsal, and on the right foot on the fifth metatarsal head. Treatment results of this patient: I had initially had them ice, put the valgus wedging in the shoes, came back later to do the orthosis. We made lateral heel skive orthosis with a high degree of valgus correction, both with extra thick medial expansion plaster. And for a patient that had these symptoms for 3 years, within 4 weeks, the patient was asymptomatic. So this was a very satisfying patient to be able to help. And it demonstrates how effective the right type of orthosis can be if they're made with the lateral heel skive, the forefoot valgus wedging, the everted balance position, the lower medial arch, in order to produce the effects needed to increase the subtalar joint pronation moments in these feet that are needed to treat these people who are over-supinating. So in conclusion, this lateral heel skive technique is very powerful. It can increase the subtalar joint pronation moments to treat subtalar joint supination pathologies such as lateral column overload syndrome, chronic inversion ankle sprains, or peroneal tendinopathy. And again, the lateral heel skive by itself does not work as well as when it's combined with other parts of the orthosis, which I've mentioned, which includes the valgus forefoot wedging, the lateral column filler, and the everted balance position, and the lower medial archite, in order to treat these patients the most effectively and to produce optimum therapeutic results with the orthosis for patients who have this pathologies. Well, thank you very much for attending these 4 lectures, and I hope you all have a nice day.